So today we are going to walk through our regional opioid map, our regional opioid strategy map. And so some of you had a sneak preview of this at the summit held at CMU on May 11th, and this is a follow-up to that session. So welcome today. For those of you that would like to receive updates on our opioid work group, we'd like you to take out your cell phone. This is the only time today to take out your cell phone during the next hour and text MiHIA to 22828. And this will and you're going to text your email address to this number, and you'll automatically be added to our listserv. I'd also like to thank our event sponsor for today, the Saginaw Medical Federal Credit Union.
They want you to go back.
Oh, sorry. 22828. Perfect. And again, we'd like to thank our event sponsor for today, the Saginaw Medical Federal Credit Union. They were gracious enough to host at Delta College, and I'd also like to give a special thanks to our co-chairs of our opioid strategy work group, which is Dr. George Caprano and Dr. Tom Vaverka. So thank you for helping us lead these efforts. Today, I'm going to give a brief overview about MiHIA and how this work group was formed. We're then going to walk through the insight formation strategy map. We're going to move into a panel discussion, Q&A, and then I'm going to walk us through what our next steps are from here. MiHIA has a mission and a vision to improve the quadruple aim. The quadruple aim includes improving population health, improving the quality and patient experience, providing costs at lower care, and improving the well-being of providers within our region. We represent 14 counties of mid-central Michigan and have been in existence since 2007. We're a formal 501c3 nonprofit that follows the collective impact model. Our board represents multi-sectors, including behavioral health, public health, hospital systems, nonprofits, large business, payers, and consumer voice. MiHIA is a regional asset for the Great Lakes Bay. We really look at bringing individuals to the table, building relationships, and acting as a catalyst for sustainable system change. We like to bring all stakeholders together to work on a common agenda that advances the quadruple aim. The Regional Opioid Strategy Work Group convened in November of 2016. We saw an opportunity. There was a lot of great progress going on across the region related to addressing the opioid epidemic. A lot of things were happening in silos or within one county or neighboring counties, but they weren't communicating with each other. They weren't learning from lessons, they weren't sharing successes. And so we looked at this as an opportunity, as a coordinated approach to address the opioid epidemic. We convened this work group with multi-sectors, multiple stakeholders, our board of directors, and started meeting monthly. And our first thought was, let's do a needs assessment, or let's do an assessment of all of the activities that are happening within the region. And we were lucky enough to learn about insight formation and about their strategy map, and really how we can have a comprehensive view of current activities to bring traditional and non-traditional partners to the table. We're going to start off with kick us off with about a 6-minute video from Bill, the president of Insight Formation, to give an overview of the basis of what the strategy map was created for.
This video is an introduction to strategy maps and the opioid crisis strategy map template. Strategy maps are one of the tools that I wrote about in the chapter Implementing Population Health Strategies for the book Solving Population Health Problems Through Collaboration. A strategy map is a visual representation of an aligned set or system of intentional changes that help you get from your current situation to a desired future state. And strategy maps are the flagship tool of the entire strategy management field. And this is a strong evidence-based practice that has contributed to dramatically improve strategy implementation for thousands of organizations, over 180 of which are featured in the Balanced Scorecard Hall of Fame. The building block of a strategy map is the objective. And objectives describe specific changes in how they're linked together through a cause and effect logic that flows from the bottom up to the top. Strategy maps are organized into various sections. The top section looks at the outcome objectives, which are the ends. The middle section is the strategy objectives, which are the means to achieve those ends. And the bottom section includes asset and capacity development objections, or the enablers for implementing the strategy. So a simplified subset of the opioid strategy would be to say that one of the enabler objectives is to grow a strong coalition to address the opioid crisis. And that would contribute to objectives such as reducing the prescription of opioids and expanding drug take-back and disposal programs, which would contribute to decreasing access to opioids, which would then contribute to the outcome objective, reduce the misuse of opioids. The actual strategies for the opioid crisis are much more extensive, and so we borrow a concept from Google Maps in the ability to zoom in to specific details of the strategy and then zoom back out to see the big picture. About 3 years ago, we began merging together strategies from many of the national strategies or state strategies or research reports into a comprehensive template. And that's what I'm sharing here. The top section has the outcome objectives, such as reduce opioid drug misuse. The next section then organizes the various strategies that are drivers of that, the drivers of those strategies, and then down to the asset and capacity development objectives. The pluses indicate that you can zoom in to more detail, such as here, where we zoom in to the detailed drivers of reducing access to opioids. And this includes things like expanding the PDMP, or improving safe storage, or expanding prescription drug take-back and disposal programs. The minus allows us to zoom back up. Strategy maps provide a stable and streamlined strategic framework that you can use for multiple years because it doesn't contain the specific actions that can be quickly completed. It doesn't include the targets or the measures, although those will be added. Having that stability and that simplicity clarifies the system thinking of the various causal drivers in this strategy. And as a community picks from this master template or catalog the strategies that they want to do, they can then build out the details of how they want to do them, who's going to work on what, and so on. So the strategy map is an ideal tool to create a common agenda for collective impact. And it allows the coalition to organize other details that are key for successful strategy management, such as having a powerful set of measures based on the outcome objectives and the driver objectives, and the ability to then organize mutually reinforcing activities where the community works together to accomplish those objectives. And a structure like this allows many places across the country to share information more easily, such as using the Opioid Coalition Resource Hub, which is a free Wikipedia-like resource structured based on the strategy map, where you can navigate to objectives, click on an objective, and get additional facts and details, different promising strategies, programs, campaign details, products and services that can support this objective, as well as tools and resources that can be shared, such as training materials, marketing, education and awareness tools, and videos and more. So for creating the template and the Opioid Coalition Resource Hub and some of the other supporting tools for coalitions, I received the Communities Joined in Action Health System Transformation Award in 2018. So you can learn more by contacting me by email or visiting our website at insightformation.com. Thank you.
So are we ready to see the MiHIA's region opioid strategy map? You're going to locate this on the MiHIA website, www.mihia.org. There is a small tab up on the right that's labeled dashboard. The strategy map is housed on our dashboard. This is a publicly available source that was co-funded for our region to track progress in the quadruple lane. It has geomapping capabilities. It's a project management hub, links to funding sources, as well as different interventions and resources. So this is your one-stop shop, not just for the opioid strategy, but for all data across the region, health and economic data. We are going to click. Once you land on the opioid strategy map page, you will see our version of the comprehensive strategy map. When you look at the dark purple boxes, those are the 10 macro strategies that we will be working towards. And as Bill had indicated, as you move through and you have zoomable capabilities, when you click on each of the macro strategies, it brings you to a variety of different interventions or activities that will help address that macro strategy. So what we're looking at right now is the strategy of reducing use of gateway drugs. And as you file through the different list of the interventions, one includes highlight positive role models and pathways. Another, expand program options for chronic disease management. When you expand on that, you will see a list of organizations or entities within the region that are doing some activity in that space. As you click through different activities, you'll see a lot more interventions. So expand school-based prevention programs. We have things that are going on throughout the MiHIA region, as well as Bay, Gratiot, Huron, Midland, and Saginaw counties. Then it lists the individual organizations that are doing something in that space or in that intervention realm. As you scroll through to the bottom, there is a pin dot map of where those organizations are located and how you can contact them, the resource type, the location, and what topic area they're focused on. If there is additional resources that you're interested in, there is a link called Promising Programs and Practices. As you click on this, this will look familiar from the video that we just saw. This acts as a hub of information for individuals to go and look through to find promising practices, promising programs, different tools and resources that are available, scorecard building, and then also at the bottom, it will list your sources of information. There's also an opportunity to submit additional activities that are being included in this resource, our strategy map, noting that this is a living, breathing document. This isn't the end, this is the beginning, and that we will continue to build out the interventions in this strategy map as our efforts and as our activities increase throughout the region. So noting if your organization isn't listed on the strategy map, that's not because we overlooked things or that we're not interested in including your organization. What we would ask is that at the bottom of each of the strategies, there is a link, and you can go in and complete the Google link and share your activities that are occurring within your organization. So noting that this document will continue to grow and become more robust for our region. As you go through the different macro strategies, you'll see that some have much less interventions or fewer interventions than others. So as we start building out, for example, shift from punishment to treatment approach for opioid users, and we look at alternatives to arrest, this is an area where there's a lot of activity. There's programs in this region, there's programs that are statewide that we can leverage to help improve this area. And as referenced, this is the area here where you will click to add more interventions to the opioid strategy map. Something else that the work group has been focused on is, okay, we have this information within the strategy map. How do we have a comprehensive view of where there's potential gaps? And that brings us to a sample display of one of our strategies. We've taken the listing of interventions or activities that are going on and have color coded it. So if there are 3 or more organizations or entities doing something in one space or one intervention area, it's green. If there are less than 3, it's yellow. And if there are 0, it's red. As you can see, we have a lot of red. We also have some green. And so in the areas where there's green, how do we share those best practices across the region? And in the areas where there's red, how do we have a coordinated effort across the region to improve in that space? So this can be used as a needs assessment for the opiate epidemic within your organization. If your leadership is looking at what do we do, how do we affect this? This is such a huge problem. We don't even know where to start. This opioid strategy map is a great place to start. So the current strategy functionality, it definitely enables referrals. If you have an individual that comes to your place of service and you need to connect them with a resource, you can go to that pin dot map and know exactly where to send them. It illustrates our strengths and gaps that we have in this region and can also connect key partners across county boundaries. What is the future functionality? Well, we hope that at some point this map incentivizes a regional strategy for funding, and that we can use this to approach large funding organizations to provide dollars for this region to help us address this epidemic. In addition to that, the dashboard has the capability to house real-time data, and that can help us measure success and progress. So there may be information within your organization or within the region that we want to track and we want to measure on a weekly, bi-weekly, monthly, quarterly basis. We have the capability of adding this data into our dashboard, setting up specifically created pages to help us measure progress. In addition to that, it can help provide technical support, not just with the resources and the interventions, but how do you implement those? What's the program planning piece of actualizing or operationalizing those interventions? We're going to now bring our 2 panelists up and talk through some of the positives and share their opinions and their reactions with you all. And then we'll move into a question and answers portion of the agenda. So I'd like to welcome Dr. Kathy Bazzi, MiHIA Board Chair, and Joel Strauss, Public Health Officer for Bay County Health Department. Welcome. So Joel, we'll start with you. Having been involved in the opioid work group since 2015, can you talk to me a little bit about how things have evolved from the initial approach to current day?
Well, we've come a long way in a short period of time. So in 2015, just to give you some background, the health department received a call from a Clarendon Bay region saying, and we have a number of these overdoses occurring in the community, and we don't know what's going on, and we thought, okay, maybe there's a handful. When we took a look at the data that was provided to us, it was a pretty big eye opener because it was clearly a cluster that was taking place, and one where we had more than a dozen people overdosing in a matter of a few weeks. So we got a meeting together with the prevention and treatment community, law enforcement, courts, and others in the community. And those first meetings were was a big education for me because a lot of biases that folks had, and even myself, about opioid use, thinking that it was a problem in large metropolitan communities and not one that necessarily would affect a community like Bay County or Bay City. That was a big eye opener, and we had to really work to get people to change their minds about how we approach this situation. For example, and I don't mean to pick on law enforcement, but a lot of people thought, well, this is a law enforcement problem, just arrest them, lock them up, and the problem will solve itself. And even many of the law enforcement agencies believed that, but they also knew and actually came around in a short period of time that it's really a multifaceted problem, that it involved the local health systems, social service agencies, businesses, schools. And it wasn't just a matter of going out and doing drug prevention education in schools. Because the fact of the matter is the people that were really being affected by this were well beyond high school. They were adults all the way. The median age was about 29. But really it affected folks from their mid-20s all the way into their 60s and 70s. And so putting together a series of meetings and coming together as a community and really talking to the community and finding out what was going on and finding out what we needed to do, because there was quite a gap in information, and that was one of the big obstacles that we have had and continually have had. So this is a very good start, I think, because not only, because we worked in a silo in Bay County, I mean, we've had umpteen different opioid town hall meetings, so much so now that they've become almost too commonplace. And but we've done some good work. We were one of the first communities to really distribute naloxone and train first responders for that. But we also realized that there really needed to be a more heightened sense of urgency into this, and we needed to procure more resources for treatment, particularly medically assisted treatment. One of the things that we learned pretty fast is that this isn't just a prescription drug problem, that a lot of folks followed just the basic economics of the situation and moved into heroin and fentanyl. But unlike a prescription drug issue where it's a controlled substance and you know what's going into what's being prescribed, you don't know what the drug dealers have out there. And so around 2016, we started to see that many of the overdoses and deaths were related to fentanyl and carfentanil. And so that's one of the things that we've really been struggling with in the last few years. In fact, the number of overdose deaths has actually rose in the last year, which was quite a surprise to us because we really did quite an effort in the community to provide naloxone and Narcan to first responders and the families and people. But the thing I like about the strategy map is that you have to start somewhere, and there are so many facets to it that need to happen, especially regionally. And as I said before, I'm talking about Bay County, but as we begin to speak to others in neighboring communities throughout the state, we're finding that it's not just us that has the problem. These are problems that are happening regionally and really throughout the state. Today I saw a report from Calhoun County, which is county seat or the county of Battle Creek, and they have quite a problem with opioids, as everyone does. And one of the interesting assets or facets of their report is that probably about 60 to 70% at least of their deaths and overdoses were particularly related to fentanyl use. And for most people, they don't think that they're buying fentanyl, they just think that they're buying heroin. So that's one of the things too that we see is, as I've said before, that we really need to work on together as a community. Of all these things, in a public health, this is, as I said before, it's a public health issue. One of the things that we're most concerned about is trying to promote harm reduction along with this. We're talking right now, I've been talking about just overdoses, deaths, but there is a much greater problem on the horizon with chronic disease associated with IV drug use. We have seen our hepatitis numbers in Bay County and the state of Michigan really go through the roof in the last few years, particularly hepatitis C. We are in the midst of the biggest hepatitis A outbreak in United States history. And that is happening throughout Southeast Michigan and including this region.
And so Joel, to build on that point, everybody in this room has a role they can play. And so from a public health policy perspective, how can this map help?
Well, it's a good thing because it treats the issue as a public health issue, but it also treats it as a multifaceted issue. And that's one of the good things. It's not just, this is the health department's problem, they're going to take care of it. Because quite frankly, we don't have the resources to take care of it. And it's not just a law enforcement problem because you can't arrest the problem away. It really is a problem that affects all sectors of the community, whether it's hospitals, social service agencies, schools, I mean. So we're treating it as the multifaceted issue that it is. It is promoting more treatment opportunities, especially medically assisted treatment, which is a very good thing. It's something that's sorely needed within the community. It's getting law enforcement, courts, healthcare, governments, local governments, schools, churches, and businesses together, as we are here today. And it's a problem that's going to affect us for quite some time. And as I talked about, harm reduction is a big part of the strategy.
Exactly, and that's something that most strategies don't include is harm reduction. And that this is a macro strategy of how do you reduce harm, if it's a safe needle exchange program or what it be, but how do you work through the continuum to have this solved?
So we need to be open-minded about some of the solutions that will present to us in the next months, years to come. A lot of things are very controversial. Needle exchanges are controversial. We don't want to be enablers for an issue. But at the same time, we don't want to promote disease by turning a blind eye to what is going on. So we've got to be open to new solutions. We've got to be open to sharing information, not only just within our own communities, but throughout the region as well. That's, I think, one of the big parts of the strategy that I think is really, really makes an effect.
And that's exciting with the dashboard that we can house real-time information that organizations can put in and share across sectors too.
And then finally, I think we just have to review, reinvestigate, and reinvest, as we've talked about going in from a phase 1 to a phase 2. One of the things that just, I'm thinking in a phase 2 strategy really should be is that we really need to work together as far as autopsies and medical examiners go, because that's often the first line of information that we get about the extent of the opioid problem. But it's one that's difficult to cull the information because we don't have a central database of deaths here other than what's reported to the state, and that's often delayed months on end. So if we can start to work together as communities and start to share information and even to strategize with law enforcement agencies and treatment centers and courts, we really can get a good grip as to where some of the issues are and where we need to reinvest in the future.
Thank you. Thank you. So Dr. Bazzi, we'll jump to a couple questions for you. What does this regional opioid strategy map mean for the Great Lakes Bay region and our 14 counties?
One of the most important things about it is that it's public domain and it's free. And so virtually anybody can access this through the MiHIA website. And I love it because this is a true complicated, comprehensive system problem. This is not a easy to solve issue. This is one of the largest epidemics from a public health perspective that we have faced, and it will take many stakeholders to solve it. And having, so this strategy map, I love it because it's first of all, it's a conceptual framework. It's a mental map, and it meant a lot to me to be able to just look at it and see what are all the kinds of things that are going to need to happen in our community if we're going to be successful solving this. And to get all of those in a relational diagram on a piece of paper that you can look at or on a screen where you can see the full picture of all the required pieces of an idealized strategy to address this in your community, that was a big thing. So this thought map is a good help from that perspective, so that if you're any part of this, you can look at it and see, this is what I'm doing, but somebody else needs to do all these other pieces, or we're going to just keep fighting this battle. And so this allows us to see who's doing those other pieces. So and it's real and granular for our community. So it's not just a conceptual map, it's an actual map of who's doing what in our community. So as a service provider, if you want to find somebody to refer a client or a patient to, you can use it for that. Or if you're a service provider and you're trying to figure out who are the people you're handing off to, or who are your partners, that is out there as well. Similarly, it allows us to see who are the people that are doing something similar to what I'm doing, so I can connect with them and see if we can either work together or learn from each other. And although it's nice to have this wonderful map and to see the whole strategy and see who's doing what, if it's not used, it's virtually worthless. So it's incredibly important that people use the map and add yourself into, if you know of a service or a service provider who's not in there, make sure you go in and add that information. That multiplies the value of the map. In addition, we want to make sure that we're looking at those gaps. So if we've got 60% of what's needed or 50% of what's needed is happening, and we can clearly see, as Beth just illustrated, where those red areas are, where it seems that nobody's doing something. Either nobody's working on these 6 things in this county, or nobody's working on this in any county. One of the examples of that is alternatives to opioids for pain management. Comprehensive alternative. So if people will still have pain, that's a reality of life. There's going to be people who have pain. What are going to be the processes and support services available to people from a comprehensive plan? We want to make sure that those exist. So where there are gaps, we want to bring people together to close those gaps and fill those needs in the community. So we have this event today to illustrate the map and get people aware of it and using it as a true asset to our community, a public domain asset that's out there. There will be other times in the future, and one coming up in August, I think Beth will talk to us about that, where we're going to convene people to work literally on the gap spaces and bring partners together to strengthen the current activities and address gaps and form partnerships in an even stronger way. But you don't need to wait for somebody to facilitate that, because all the information is on the map. Everybody should feel empowered to go use it.
And to build on that, this event was the first. It was the stepping stone. It was adding, community involvement and engagement on the strategy map to increase the utility of this. So with it being public domain, we want organizations to see this as a huge resource to their organization, to the people they serve and so forth. So one additional question, Joel and or Kathy, how can this strategy map be leveraged for potentially other priority areas or other areas that we want to address as a region?
I'll start. This tool is on the MiHIA website under the dashboard. The dashboard is likewise a public domain, and virtually everything MiHIA does is a public resource with 100% transparency and utility for the community. This capability of having a strategy map and one that has that drill down capability from the higher level elements to the sub elements, and then even linking to the resources of what can be done, where are the evidence-based interventions, where are the best practices, where's the data. This can be used for, I guess this is good news, bad news situation. The good news is we have this capability for complicated and challenging issues which require many different stakeholders to work effectively together to address that. The bad news is we have more than one opportunity where that need is present. You know, the opioid epidemic is one, but other chronic diseases, take any of them, obesity, take mental health challenges, they all are complex, challenging, comprehensive sort of problems which can be done using this same exact mapping strategy and can be managed that way for the community. So it's our intention to use that leverage capability to address other practices and challenges in the community as well. You can see how all the same capabilities can be leveraged through that model.
I think chronic disease management, chronic pain management is a first big step in this, as you mentioned. I also see its opportunities too, where we can reduce the burden that's put on local law enforcement and jails and courts by really promoting drug courts and the provision of assisted treatment in some of the local jails, especially pre-sentencing. And that way we can get folks back to recovery in a faster path if we can do that. And then finally, too, I want to say this is a strategy that's part of the dashboard, but it's something that it's been around for a while, but it's really starting to catch on more and more now, is that local law enforcement agencies are opening to having the drug take-backs right in their facilities. And this is great because not only, number one, does it get the supply of opioids out of the hands of people that really shouldn't have their hands on it to begin with, but also it takes it out of the water stream. So it's good for the environment as well, rather than having people flush their opioids down the toilets, because those aren't treated in your local wastewater treatment plant. So, there are several initiatives like this throughout the whole strategy, I think, where it's going to have beneficial effects on other issues as well.
Before we open the floor for question and answer, and then we move into now what with this, now what, where do we go from here? We have a few of our opioid strategy work group members in the room, and I just want to open the floor if there's any of them in the room that have any comments or feedback on the map's evolution, those that were a part of the summit at CMU on May 11th. If there was any additional comments that would like to be made before we move into question and answers from the group. Right in the back.
Come on.
Tom, you can come up. Come on up.
Let's use the microphone here.
Yeah.
I'm a physician, and looking at the strategy map, I think to highlight the complexity of the issue, we have to recognize that if we impact one area of strategy map, that can then have downstream effects in multiple other areas. And one of the areas that I'm very concerned with, recently the legislation has been enacted to really start ratcheting down on prescribing opioids. And as a physician, I think that's great, because obviously we need to cut off the supply at the front and try to avoid an excess of prescription opioids out in the community. But what that sets us up for then is there's a group of patients out there that are dependent on opioids, either for pain management or they're just physiologically dependent. And they relied on their prescription drug source. And I'm speaking with a lot of my colleagues, as the legislation has ratcheted down on our ability to prescribe opioids, a lot of them are just saying, well, I just not prescribe them. So there's going to be potentially this cutoff of people that have relied on, for good or bad, they've had their opioids for years, for several months. It's going to be cut off, and where are they going to turn? Well, there's a cheap supply out there, unfortunately, they're on fentanyl. And so I'm afraid we're going to see this uptick in opioid overdoses, because the danger is much greater if they're injecting illicit opioids, that they have no idea how much fentanyl is in it. And so we could be creating a greater problem in the short term. Obviously, in the long term, we want to cut off the supply. And you see that in the opioid strategy map. It makes a ton of sense. It's cut off the prescription opioid supply. But then what effect does it have on the rest of the opioid strategy map in terms of overdose deaths and that kind of problem? So, and we're woefully short on treatment availability for medication-assisted treatment for people who are addicted to opioids or for chronic pain management. And it's underfunded and undersupplied. So it just highlights other areas. And I'm very concerned. We're right at the cusp of potentially seeing even further uptick of overdose deaths. Just a comment on that. It's just a perception.
A great comment, Tom, and it just shows why every part of the map has to work for this to really be successful. If you just cut off this prescription supply, you've got to have those effective detox and treatment facilities. You've got to have effective alternatives to manage pain. You've got to have the whole picture. Otherwise, the solution space isn't working.
Got a question in the back?
Thank you, Dr. Berger. I'm Dr. Kaziki. I'm in Michigan Neuropsychology. I work with pain patients who've been on opiates for over 10 years. And the problem they're going to run into is our emergency rooms are going to cut them off when they order to get their opiates. They're not going to be able to get in the street. They're going to start raiding everybody's medicine cabinets and so forth. We need to create some kind of amnesty issues for some of these people, particularly with the first responders and so forth. Otherwise, they're going to go on the street. And we need to work together. And we need to get law enforcement. I know there's some prosecutors here. We need law enforcement to send a message out to the user community out there that there is another method for them to get access. We need to give them a ramp, a time frame to get off these opiates. Otherwise, these guys here are going to be opiate enforcement, and they're going to be arresting a lot of people. And they're going to be your moms and dads, and your uncles, and your aunts, and your sons, and your daughters. And what are we going to do then? So I think that this has to be really methodically looked at, particularly when I look at the patients who are using opiates that I work with. Most of these people are just average people who were told by their doctors that they could take these things without any problem. This is a real emergency that's going to blow up even bigger than I think most people here recognize.
You're speaking to one of the issues that I think is so acutely illustrated in the map, which is if we don't have sufficient alternatives to manage those folks, there's a big risk. And so look at the map and see where the red zones are, where how many options do we have for people who are either trying to get off of their opioids because they're already on them, or those people who need some management of pain, but if opioids aren't available, what is the full scope of services that are available to them? And we need to build those capabilities in our community for exactly your statement. Thank you for it.
And this map can be used as a capacity building tool as well, and looking at the red and making sure that we have the resources once other parts of the map start in play. Dr. Kakano?
Thanks. So just to your point, I mean, the map is not the solution for the opioid crisis. It was that simple. Anyone else in the country would have done it. This is just a blueprint of resources available for the region. The one thing to keep in mind, this is not hospital-specific, physician-specific. This is regional agnostic to physicians, counselors, hospital A or hospital B. Yes, Dr. Berka, I mean, as you know, I mean, the 4 hospitals in the region, Bay, Midland, and Isabella, came together a year and a half or so ago. From the emergency room, they had door-to-door one protocol. New scripts, refill, I mean, so patients, addicts, other, I mean, they're not shopping from hospital A to hospital C. They get the same answer there. So at least that coordination effort from the emergency room across 4 hospitals has been very fruitful. Lots of other efforts are happening, but that captured in the map, but this is a dynamic open process. So if you know of any resources happening in Midland and Bay or others, people can go and add this. The other good things, I mean, substance abuse, mental health come hand in hand in many areas. There's another mental health initiative that we're working on. Hopefully, we're going to use the same inside software in here to create a group tool for this mental health resources. So you can flip from book A to book B, find out where the mental health resources are, where substance abuse, find what the overlap is. So I think this is a starting point for other things. The next part 2 of this can be mental health.
Thank you.
I just want to add to the last couple of comments is that, you know, people have basically about 4 different types of treatment options, if they can find treatment, which they normally can, but there's Vivitrol for medically assisted treatment. There's Vivitrol, Suboxone, methadone, and then for others, it's just going off cold turkey. But there's also counseling, and counseling is often an integral part of medically assisted treatment. You just don't try medically assisted treatment alone. You also have to work on behavioral health issues as well. But the one thing too that we need to acknowledge is that the average person that is addicted has about 7 attempts through rehab before it finally really merits success. And so it's something that, you know, it's not just a one and done kind of thing. It's something that people are going to have to live with all their lives, and something that we need to acknowledge is that it's not just a short-term solution.
In addition to those medication services that you have, there's non-medication supports for pain as well that are very important, but are sometimes in short supply or are not recognized. So for musculoskeletal pains, for example, sometimes, you know, obviously people think about physical therapy, but there's also a lot of mind-body therapy practices that are very useful in that regard, and even yoga, massage, using other sorts of mindfulness practices and meditation, neuromuscular re-education. There's a variety of other things to consider, either as an initial approach to pain management or as supports for people that are looking for alternatives as they're trying to get off of opioids.
Any other questions before we move on to the what's next or what now? Got 2 more.
This may be a little bit beyond today's purpose, but I know that one of the strategies is to reduce use of gateway drugs. And with the effort this year that apparently will be going forward on the ballot to legalize recreational marijuana, you think that's a huge concern out there about information and misinformation that's out there. I'm just wondering, I mean, I think that's something that needs to be immediately addressed. I'm just wondering if there's any particular strategy in place to try to deal with that on an urgent basis.
So at this time, we've not selected what specific macro strategies we'll be focusing on. That gets me into the what now, what next piece. There's absolutely individual organizations that may choose to use that portion of the map and start moving ahead with some activities that when we encourage that based on where you are as an organization. But at this time, when we get into the what now or what next portion, we'll talk about how MiHIA plans to facilitate further the use of this map. There's one more question.
Hi, thank you. I really appreciate this. I think it's a fantastic resource, and I think the dashboard is such a gift to this region. It's really remarkable. One of the things that I wanted to ask is you've got outcome objectives listed here that are very clear. But when I looked at the database, it looks like only one of those outcome objectives is actually now part of the database. So or the dashboard. I may have misunderstood that, and I'm just wondering how is that, how are those outcomes going to be continuously updated?
Absolutely. So as we start moving into the intervention implementation space and building out a program plan or our game plan for the region, we'll start looking at what the outcomes are, making measurements, setting benchmarks, intervals of when we're going to be measuring or monitoring, and then as well key milestones. So we'll be setting those as we evolve with this. Any final questions before we move into the what next?
Maybe just mention about Katie, who's our leader.
Yes, so that's actually, so what now? So our quadruple aim leader or facilitator is Katie Trotter, who unfortunately got the stomach flu this week. And so she was not able to be with us today. But she will be leading these next efforts. And the next step is something called a Community Coalition Accelerator Program. And we're going to be working with Insight Formation, who has conducted their first Community Coalition Accelerator Program a few weeks ago, and they'll be coming to our region in the August timeframe to help us advance this strategy map. So the program is really designed to improve the engagement of all sectors. We started off with saying that everyone in this room has a role they can play. Well, now what is that role? And how does your organization fit into each of these strategies? How can we work together to achieve success in these strategies using the measurement and data piece? How do we improve upon the measurement and data? And then in addition to that, what are some available and low cost resources to help advance our region in addressing the not just the opioid epidemic, but how do we seek out funding and what resources have been utilized in other pockets of the United States that have been successful? And so looking at lessons learned and bringing them to our region. This will, there will be a 2-hour pre-workshop that will take place in the July timeframe. And then in the second week of August, or first full week of August, I should say, we're going to be conducting a 6-hour workshop with up to 80 individuals from partnering organizations. And we're going to learn non-traditional ways of collaborating, valuable new tools to advance key parts of this strategy map. And then also there will be 5 tracks we will be selecting. 3 of the tracks are pre-selected, or 3 of the macro strategies are already selected from Insight Formation. And then as a work group, we'll be selecting 2 tracks that are unique to our region or unique to what priority areas we are wishing to advance. In the late August, early September timeframe, there will be post-workshop webinars and then additional coaching sessions. What the most exciting thing, I think, from my perspective is out of this workshop, we will have a short-term and a long-term work plan at the end of this August session. So if you're a behavioral health provider, if you're a yoga instructor, if you are an emergency room doctor, what can you do in each of these 5 macro strategies that will help improve this space? And so it's not just now we have the data, now we have the map, now we can really look at accelerating and acting as a catalyst for our region to improve progress. So how else can you be involved? First, share information. There's the Google link on the MiHIA dashboard where you can submit ongoing information. You can participate in the Community Coalition Accelerator Work Group. All of those that have texted their email address, we'll close with that last slide again. Please submit your email address. We'll be sending out a save the date on an invitation for that. Once the date's finalized, we're looking at either Tuesday, August 6th, the 7th or 8th of that week. Get on our distribution list for ongoing updates of information. You can participate in the implementation of the work plan once we've developed that. And then lastly, be an advocate for regional positive progress. And again, to join our mailing list, 22828. Remember, what we do today can improve all of our tomorrows. It's going to take each of you in this room plus more to help us address this opiate epidemic. And I've been born and raised in this region, and I know how resilient this region can be. Let's put ourselves on a map of how we can make positive change. Thank you. What's wrong?
Sorry, I have a question. I thought the questions were just for people who were part of the committee previously.
Oh, no, sorry. Go ahead.
So I got, lots of them actually. So one of the stuff I was noticing.
Right.
I agree with the young lady who was over there, that this is an extraordinary thing that's happening here in the Great Lakes Bay region. I was going to be late here today because I needed to take my niece who had been relapsed in her heroin addiction. And so fortunately she was able to figure something out. Anyway, I love the strategy map. I think that there's something even deeper, like on the base, the foundation of it, that I haven't heard addressed. And what I was wondering is, one of the doctors had talked about mental health and that being a part of the challenge that we have. So in the experiences that I've had in working with opioid addicted individuals is that it's not just a drug problem, it's an emotional problem, and it's PTSD problems, and it's a lot of, like you were saying, Dr. Fossey, the emotional side of things, and so behavioral therapy, things like that are wonderful. I think that there's a lot that we could do in the mental health and CPS, and then the treatment centers as well, where we could provide a lot more training for the people who work so hard, because I think most of them are overworked because of everything that's happening and the amount of people that are addicted. So my question is, when does that get covered? I'm going deeper actually than this foundation that we have here.
Well, Dr. Picano started to mention this, that there is a work group already ongoing around mental health with a full strategy, planning to use the same tool and the same information around mental health, and he's coming to share that now.
Thanks, we're pretty aware of this. I mean, mental health actually is probably the worst crisis in the Great Lakes Bay region than the opioid epidemic as we speak here. Just this morning, I mean, someone shared the story. I mean, high-level executive from the hospital CEO for a mental health appointment for one relative. First available for a new patient is 4 months. This is after the hospital CEO of the meeting. You know, these are employed physicians by a hospital. This is how bad things are. Leave alone, I mean, counselor, social worker, other whole thing. So there's a small group. I mean, if you're in third class slide, that's a separate discussion. One subcommittee that's going between MiHIA and the Great Lakes Bay Alliance, and the Mental Health Coalition. Unfortunately, part of it actually just hired a director. We're meeting that person sometime this evening, actually. This is my next meeting. To start to build a strategy map or build resources, ultimately leading to a clearinghouse referral center for mental health, like having 211, like having 911, like having these resources. Hopefully, it's going to be a year, 18 months from now, that resource center will be available for the region. Actually, this is my next meeting. Actually.
I'm really also very happy that you had the non-medical side of things. As far as the massage therapy, yoga, all those things are wonderful. I'm a holistic health therapist, so of course I work in that area. But the other part of it is the non-medical therapies, as far as diet and supplementation, things that are proven on PubMed, so there's lots of studies on things, and I think a lot of people don't know about them. And so I'm wondering, is it for us as health and wellness experts to join the committee to help share those things?
You can share them through that link and they'll be added. We'll have a pin dot, available contact information, and organizations can act as referring entities to your group and so forth. So we can definitely submit that and we will make sure that that's included in our map.
Okay, and then as far as the subcommittees, how do we become a part of those?
They will come out of the Community Coalition Accelerator Program and what our work plans are and where we decide to take action.
Okay, great, thank you so much.
Absolutely. Perfect. Thank you all for today. I appreciate you taking time out of your afternoon to spend time with us and hope you all have a wonderful evening. Drive safe.